It's next my great pleasure to introduce my colleague, Vik Sahasrabuddhe. I can't say it as well as Bill can. Vik is a program director at the Division of Cancer Prevention at the National Cancer Institute. He runs a large portfolio for HPV cancer prevention. His expertise in understanding the best way to use existing vaccines, ways to look at novel vaccines, ways to triage cervical cancer preventions, and how to do this not only in the US but around the world. So without further ado.
Thank you, Tom. So thanks, Tom, and thanks, Bill and Less Cancer for having me here. It's the third year in a row I'm coming here and talking about our work, primarily to talk about some of the work that NCI undertakes related to HPV and cervical cancer prevention, or broadly HPV-related cancer prevention. I think it was perfect timing for me to talk right after Rachel did fantastic talk and great survey, and thank you, Dr. Carney, for getting something like this started. I think it's a great opportunity to highlight some of the challenges related to uptake of HPV vaccines. As Rachel alluded to, this is one intervention that is older than the oldest iPhone. It's older than Twitter. It's older than Google Maps navigation. It is something that's available since 2006. Seems not too long ago, but it is older than all these inventions, and yet only half of all eligible children in the US get this vaccine, primarily because of so many misconceptions around what the vaccine causes, whether it would lead to increased sexual activity. And as Rachel said, there's so many misconceptions around the vaccine being labeled as a vaccine to prevent a sexually transmitted disease, that if we change the conversation and make it around cancer prevention, that changes the dialogue considerably with parents, with providers, that provider-parent communication. In fact, NCI has invested efforts and resources into learning what might be those improved approaches to increase provider-parent communication. And there are organizations like the CDC and the American Cancer Society who are also working on this through something called as the HPV Roundtable. You can check out that website. There are a lot of resources to look at what might be the facilitators for some of those conversations. But simply the spectrum of cancers that the vaccine can prevent. Cervical cancer, as you know, is one of the commonest HPV-related cancers globally. About 500,000 women get cervical cancer every year. 250,000 or more die due to that cancer. It's an entirely preventable cancer. The problem is it's not fully prevented, particularly in parts of the world where there is lack of access to resources and lack of trained manpower. What we are doing at the NCI is trying to find several innovative approaches to get over this gap. One of the things in relation to the HPV vaccine, what we are focused on is trying to see if reduced doses of the vaccine can be as beneficial. When the vaccine first came out in 2006, it was a 3-dose vaccine series. As a result of some of the efforts that NCI and other partners have undertaken over the years, it's now only a 2-dose vaccine series that's currently recommended for children under the age of 15. So if you're vaccinated before 15, you're only recommended to get 2 doses. If you're over 15 and up to the age of 26, you can get the full 3-dose series. But what we are now trying to do is trying to see if a single dose of the HPV vaccine may be as beneficial as the 2-dose series. And this is requiring to mount a very large clinical trial, which we are currently undertaking in the country of Costa Rica in partnership with the government out there to see if 1 versus 2 doses would work equally well. And we are going to study this in a large population of about 20,000 girls and boys and trying to see if they mount an immune response and have a benefit of the vaccine in terms of prevention of HPV infections per se that might lead to a change in the WHO and CDC recommendations around vaccine doses. But that might be a game changer because consider how many people can be vaccinated with double the dose that might be available if you change it to a single dose schedule. The other thing we are doing in the context of screening for cervical cancer or other anogenital cancer is looking at newer and improved approaches. One of the mainstays of screening has been pap smear screening. I don't know if this was talked about earlier, but pap smears are the frontline mode of cervical cancer secondary prevention in the US for several years, several decades. In fact, that has led to a decline in cervical cancer incidence rates over the last several years. But there are still challenges to uptake of pap smears, which is why 13,000 women continue to get cervical cancer in the US every year. I think every case of cervical cancer represents one of the greatest public health failures of our times because it is fully preventable, yet it is not still prevented. So what we are trying to do is trying to see what might be those barriers to uptake of pap smears. So we are recently launching a study called as Last Mile that will actually take a self-screening approach to HPV. We are going to use a simple home-based or a clinic-based swab that a woman can collect herself and then try to see if that swab is comparable to an HPV test collected in the clinic by the physician. And if that validation is done and the FDA approves that assay as an approach, it might suddenly open up an avenue for taking screening to the last bit of women who do not get screened, and therefore we get this totally unintended rate of 13,000 women getting cervical cancer every year. So in addition to that, we are also focused on a visual method of screening, particularly for low resource settings where there is no current good screening approach and trained people to do colposcopies or do cervical cancer diagnostics. So we're using a machine learning or an AI-based approach to look at the cervix through a cell phone camera, through a screening approach done once, but eventually will replace the need for a highly trained physician or a gynecologist or a nurse practitioner for that matter. But AI can quickly give a diagnosis or at least a triage whether this should be referred or treated or can be sent home safely. So some of those aspects of clinical trials, clinical prevention research are what NCI is supporting through a range of colleagues across the world, including our good friend Tom Uldrick here. We are in fact working with Tom and colleagues in a new network focused on HIV-infected or HIV-positive people globally, particularly in the low and middle-income countries of Latin America and the Caribbean region, where we have launched a new initiative focused on improving approaches to primary prevention, to secondary screening and triage, as well as pre-cancer treatment, because the current methods of treatment of pre-cancer involve surgery, removing of the cervix, and somewhat of a excisional and a high burden method. So we are trying to look at newer approaches, including immunotherapeutic approaches and topically applied approaches that women or men can actually use themselves to treat their HPV. But again, these are very novel, and because NCI works at a whole range of research that extends from basic science all the way to translation and implementation and dissemination, we are taking that approach of improving some of our understanding and knowledge about HPV and translating it into some of these interventions globally. The principal deputy director of NCI, Dr. Doug Lowy, and his colleague John Schiller were amongst the inventors of the HPV vaccine. So we have a rich history at the NCI for improving on some of these knowledge, basic science knowledge that's generated as a result of taxpayer generosity and efforts that have led on to these discoveries. And then we are now trying to take it into scale and trying to prevent cervical cancer globally. So I can stop with that, but I'll probably open to questions, perhaps. Yep.
Health field questions, because we have Congressman Upton here, and we want to be able to get everybody in. Does anybody have a question out there? Do I see a hand go up, or are we all set? Are we good? Okay. Back there, I'm sorry.
So I'm just curious about the cell swabs and AI are in the works. I know that we're already have a higher incidence of cervical cancer. So I was wondering, in the meantime, what efforts are underway to get access to rural and
So it's a great question. I think we are focused currently. There is a rural cancer initiative that the Division of Cancer Control and Population Sciences is funding, which includes improving HPV screening in rural areas across the U.S. And there are aspects such as improved last mile connectivity through telehealth approaches for education, perhaps, or there are facilitators for bringing participants back in or getting the results through some telehealth forms that might improve some of these access issues. Obviously, the last mile is geared towards solving that access issue. If we can send the swab home and bring this, only the positive people back to the clinic rather than getting everybody in. But it's a great question, and obviously there are a lot of challenges remaining.